by the adrenal cortex, zona glomerulosa of adrenal cortex. And what is the important function of aldosterone? It causes sodium reabsorption from the distal tubules. So it preserves the sodium level, it maintains the sodium level or increases the sodium level. Now what is the action of atrial natriuretic factor, ANF? Atrial natriuretic factor, it is a peptide secreted by the right atrium. Whenever there is increase in the blood pressure, increase in the blood volume, there is stretching of the atrium and there is release of atrial natriuretic factor. So this causes decrease in the aldosterone level and it also causes decrease in the ADH level. Decrease in aldosterone and decrease in ADH level, which causes sodium excretion. So this is how sodium level is regulated in our body via the aldosterone and via the atrial natriuretic factor. Now coming to the disorders of sodium. So we cannot consider the disorders of sodium as individual agent or individually, because the sodium metabolism and water metabolism, they are interrelated. You may heard about the poem that is Mary had a little lamb, and wherever she goes the lamb will follow her. So wherever sodium goes, water will follow the sodium. So like that, the disorders of sodium and water should be considered together. So we'll see one by one. First we'll see the hyponatremia, means decrease in the sodium level, and then we'll see about the hyponatremia. So you just remember the causes for decrease in the sodium level. So how will be the diagnostic approach in case of hyponatremia? Hyponatremia means decrease in the sodium. The normal level is 135 to 145 millimole per liter or milli equivalent per liter. Whenever the level is less than 135, it is known as hyponatremia. It is known as hyponatremia. In the diagnostic approach, first see for the osmolality. The normal is 280 to 295 milliosmol per kg. This is normal osmolality. And then see for the volume, total body volume. Osmolality and volume, these are the two important components related with the sodium disorders. Okay, so there will be three possibilities. First one is the normal osmolality, second one is the decreased osmolality, and third one is the increased osmolality. Whenever normal or increased osmolality, known as pseudo hyponatremia, false causes of hyponatremia. It mainly includes normal osmolality. The causes includes hyperlipidemia and hyperproteinemia. These are the two causes with normal osmolality and decreased sodium level. While increased osmolality, the causes are, the first important is hyperglycemia, increase in the glucose. Second one is the urea level increased, and third one is the mannitol therapy. In these three disorders, there will be decrease in the sodium level with increased osmolality. But we'll discuss this topic with decreased osmolality. These are the important causes for decrease in the sodium level. Whenever there is decreased osmolality, just go for the volume measurement. So you may get water excess, that is known as hypervolemic. Volemic means increase in water level. Okay, increase in the fluid level. And irrespective of status of sodium, there may be normal decrease or increased sodium level, but ultimately there is decrease in the sodium level. And isolated sodium chloride deficiency, NaCl deficiency, that is means normal euvolemic condition. And third one is the dehydration or hypovolemic condition. Here there is water excess or fluid excess. Here fluid is at the normal level, but there is isolated sodium chloride deficiency. Here there is decrease in the fluid level. That's why there is decrease in the NaCl level. So decrease in the fluid level along with decrease in the NaCl level. Okay. So hypervolemic, the principal manifestation in this case will be edema. This is the clinical manifestation in hypervolemic. The main causes of decrease in the sodium level includes congestive cardiac failure, inability of heart to pump the blood, congestive cardiac failure, then cirrhosis of liver, then nephrotic syndrome and chronic renal failure. These are the important causes of increased water level with decreased sodium level. Then in euvolemic causes with isolated NaCl deficiency, the causes mainly include SIADH, syndrome of inappropriate secretion of ADH. This may be due to pneumonia, this may be due to bronchial carcinoma, this may be due to pulmonary tuberculosis or iatrogenic syndrome of inappropriate diuretic and various nephropathies. These are the conditions in which there is dehydration, there is decrease in the water level with NaCl deficiency. So these are the causes of hyponatremia. Whenever you are approaching the diagnosis of hyponatremia, you should see the osmolality and volume. The blood volume and osmolality, these are the important factors which affect the sodium level or your diagnosis. Okay, now we see the causes of hyponatremia, means increase in the sodium level. So the causes for increase in the sodium level, when it is more than 145 milliequivalent per liter, or increase in the sodium level, it is known as hypernatremia. So see the volume first here. In the fluid volume, there may be three possibilities, that is hypervolemic, means there is water excess and also there is excess of the sodium, or normal euvolemic condition and hypovolemic condition. So these are the three conditions. The main causes includes, it is Cushing syndrome, mineralocorticoids, These are the causes for increase in the serum sodium level. Then normal, it includes the diabetes insipidus, either it is central or nephrogenic. So it includes the diabetes insipidus. And the hypovolemic causes. Hypovolemic causes, it includes mainly the decreased water intake. Any condition which is related with the, for example, vomiting or diarrhea with decreased fluid intake, decreased water intake, decreased fluid or water intake, or diuretic with decreased water intake. These are the causes for dehydration. Dehydration means decrease in the water level, decrease in the fluid level. These are the causes for decrease in the water or decrease in the fluid level with sodium excess, with increase in the sodium. Okay, these are the causes. Then these are the causes of increase, isolated increase in the sodium chloride with normal volume, diabetes insipidus. And these are the with increased water excess and increase in the sodium level. Cushing syndrome, mineralocorticoids. These are the causes for the hypernatremia. So just remember the causes for hyponatremia and hypernatremia. Normal level is 135 to 145 milliequivalent per liter. Whenever there is decrease in the sodium, it is known as hyponatremia. Whenever there is increase in the sodium, it is known as hypernatremia. So this is all about the sodium metabolism. Keep watching. Thank you.
A very good morning, friends. Today we will discuss about an important vitamin in biochemistry, that is niacin. It is also known as vitamin B3. Niacin is a water-soluble vitamin and also known as nicotinic acid. The amide form of nicotinic acid and niacin, it is known as nicotinamide or niacinamide. Actually, it is not a true vitamin because there is partial synthesis of niacin in our body from the tryptophan. And for this conversion, we require additional compound. For example, riboflavin is required, then pyridoxal phosphate is required for this conversion, and also iron is required. So these four substances are required for conversion of tryptophan to niacin, and 60 mg of tryptophan gives 1 mg of niacin. So there is partial synthesis of niacin in our body, and rest of the requirement has to be supplied in the diet. Now coming to the active form or coenzyme form of the niacin, it is the two important coenzymes of niacin are, the first one is the NAD and NADP. These are the two important coenzymes of niacin or nicotinic acid. It is always written as NAD plus because the nitrogen in this structure of NAD, it is in the quaternary state. Due to this, it is represented as plus. The long form of NAD is nicotinamide adenine dinucleotide, and when the phosphate is added, it is known as nicotinamide adenine dinucleotide phosphate. Now coming to the biochemical functions of NAD and NADP. In this biochemical functions, this NAD is converted into NADH, and this NADP is converted into NADPH. They involved in various oxidation reduction reactions, and this in oxidation reduction reaction they accept hydride ion. This is one hydrogen plus one electron. By accepting this hydride ion, this NAD gets converted into NADH. So there is loss of charge from this NAD, and NADP is converted into NADPH. Now we will discuss number of reactions catalyzed by NAD and NADP. By the NAD, there are number of enzymes which requires NAD as a coenzyme. Starting from the glycolysis, it is a coenzyme for glyceraldehyde, 3-phosphate dehydrogenase, then also for lactate dehydrogenase, then Krebs cycle pyruvate dehydrogenase, isocitrate dehydrogenase, then alpha ketobutyrate dehydrogenase, then malate dehydrogenase. It is also a coenzyme for beta hydroxy acyl CoA dehydrogenase, then branch chain keto acid dehydrogenase, and so on. So it is a coenzyme for number of reactions. These are the important enzymes which requires NAD as a coenzyme, that is glyceraldehyde, 3-phosphate dehydrogenase, lactate dehydrogenase, pyruvate dehydrogenase, isocitrate dehydrogenase, alpha ketobutyrate dehydrogenase, malate dehydrogenase, beta hydroxy acyl CoA dehydrogenase, and branch chain keto acid dehydrogenase. The NADP, it acts as a coenzyme for glucose 6-phosphate dehydrogenase. This one is the important enzyme. Then gluconolactone dehydrogenase. Then it is also required for malic enzyme. So these are the enzymes which require NAD and NADP as a coenzyme. Then NADPH, it is required for number of reductive biosynthesis. For example, it is required for fatty acid synthesis. Then it is required for cholesterol synthesis, for vitamin D synthesis, synthesis of steroid hormone, etc. This NAD and NADP, they are also required for supply of ADP ribose, for ADP ribosylation of protein and poly ADP ribosylation of nucleoprotein in various DNA repair mechanisms. Now coming to the dietary sources of niacin, it is present in non-vegetarian diet, that is liver, kidney, fish. Milk is a poor source of niacin. Also, it is present in cereals, etc. In RDA, recommended dietary allowance of niacin is near about 20 mg per day, or also known as 20 mg of niacin equivalent per day. Now coming to the deficiency manifestations, you can remember the deficiency manifestations of niacin by remembering the B3. There are 3 classical manifestations of vitamin B3 deficiency, that is diarrhea, dementia, and dermatitis. Dermatitis in niacin deficiency is classical. It is especially on the sun exposed part of skin, and it involves the area around the neck and hand and feet. When it involves the area around the neck, the appearance is like a castle's necklace, and when it involves the hand and feet, it is like a glove-like appearance. So dermatitis is classical, that is known as castle's necklace, and gloves and stocking appearance of hand and feet. And there is 4D also, that is known as death. If it is untreated, it can lead to the death. So these are the four classical manifestations of niacin deficiency, that is diarrhea, dementia, dermatitis, and fourth D is the death. The deficiency of niacin occurs when a patient of tuberculosis is on INS treatment, isoniazid. Isoniazid inhibits the 5-hydroxyphosphate. That's why that decreases the synthesis of niacin from the tryptophan. And when there is deficiency of 5-hydroxyphosphate itself, it can also lead to the pellagra-like symptoms. When there is heart nerve disease, it is due to defective absorption of tryptophan. So these are the four classical manifestations of niacin deficiency, that is diarrhea, dementia, dermatitis, and fourth D is the death. The deficiency of niacin occurs when a patient of tuberculosis is on INS treatment, isoniazid. Isoniazid inhibits the 5-hydroxyphosphate. That's why that decreases the synthesis of niacin from the tryptophan. And when there is deficiency of 5-hydroxyphosphate itself, it can also lead to the pellagra-like symptoms. When there is heart nerve disease, it is due to defective absorption of tryptophan from the intestine. In this disease, there is also a pellagra-like manifestations due to the deficiency of tryptophan. Then carcinoid syndrome. In carcinoid syndrome, this tryptophan is diverted for conversion to the serotonin, and that's why there is deficiency of tryptophan that leads to the pellagra-like manifestations. So summarizing the niacin, the amide form of niacin is known as niacinamide or nicotinamide. It is also known as nicotinic acid. It is also known as pellagra preventive factor of Goldberger. Then it is in chemistry, it is pyridine 3-carboxylic acid. The active forms are NAD and NADP. They are involved in various reactions, oxidation reduction reactions in carbohydrate, lipid, and protein metabolism. They are responsible for energy generation. This NAD in electron transport chain converted into NADH, and it gives 2.5 ATP. Then they are also responsible for DNA repair mechanism. Then excessive doses of niacin is also given in the treatment of hyperlipidemia. It helps in reduction of VLDL, triglyceride, and LDL level, and helps to improve the SDL level in higher doses or mega doses, that is 200 times of the normal dose. Then deficiency manifestation can occur on patient on tuberculosis, patient on INS therapy, heart nerve disease, carcinoid disease, and patient with deficiency of B2 and B6, that is 5-hydroxyphosphate. Then symptoms are diarrhea, dementia, and dermatitis, and the special appearance of neck due to the dermatitis. It is Cassel's necklace and gloves and stocking appearance of hand and feet. There is 4D. If kept untreated, it can lead to the death. So this is all about niacin.
Uh-huh. I found this on the web.